Hi, everybody. I'm Katie Moore. I'm the CEO of the Virginia Funders Network. Welcome to the kickoff of our Health Funders Networking Group. We're so excited that you've joined us today, and we're thrilled to have such an amazing panel lineup for you as well. I want to tell you a little bit about the Virginia Funders Network before I turn it over to our co-chairs and open it up for the content today. So as many of you know, the Virginia Funders Network is a membership association of philanthropy here in Virginia. And we are about to celebrate our 1-year anniversary. I've been with the organization now for almost 9 months. And this first year, we've really been focusing in 3 areas. The first is to build a solid foundation for this brand new organization. We've got an amazing advisory board, 18 of the who's who from across Virginia's philanthropic community that are leading our organization. We have 2 of our amazing staff here on the call today, Patty Koval, who many of you know, who's been coordinating all of our networking groups and programming, and Robin Mockenhaupt, who's our Director of Policy and Advocacy, is also here with us today. Thank you, ladies. And we also have been focused on really effective communications. I hope everyone's getting the newsletter. We have a brand new website, a beautiful new logo. We've just released our 2nd publication. And so we're building a solid foundation for this organization. And we're so thankful that you've come along with this ride with us. The second body of work is really around fostering a vibrant network. We have over 100 funders who have invested in the Virginia Funders Network and joined the organization, making us the largest community of grant makers across the Commonwealth. We are really focused on providing engaging learning and networking opportunities for you. We've launched 5 networking groups already this year. Today's Health Funders Networking Group being the 5th. We also have education funders, housing funders, social justice funders, and community foundations. And so far this year, I mean, we've hosted almost 20 learning and networking events for you guys, our members. So we're thankful that you have been so engaged with us, with an average of nearly 40 folks joining us for each one of those 20 learning and networking events. It's been pretty incredible. And the third bucket is around leveraging the power of this network. We now have 100 funders who are all underneath the VFN umbrella. What can we achieve and accomplish together? This is the area that we think has the most potential. Once we know each other, we're learning together. What can we do? And so we've already this year hosted a number of briefings around the American Rescue Plan's $7 billion investment in Virginia and what philanthropy's role is there. We just released a brand new report yesterday on the power and potential of policy and advocacy for Virginia philanthropy, as well as for VFN. And we're also hosting a series of learnings around the broadband opportunity in Virginia with $1 billion going into achieving 100% connectivity by 2024. And so these are some major opportunities that are facing the Commonwealth and philanthropy, and we're excited to have philanthropy working together to really capitalize on these opportunities and collectively fund some serious solutions to some of the challenges our state is facing. I want to give a big thanks and shout out to the Virginia Consortium of Health Philanthropy, which has really been the predecessor for this group. And we're welcome to all the members of the Health Consortium who are joining us here today. We couldn't do this work without the groundwork that you guys laid over so many years. I'd also want to thank Patty and Robin for all of their work pulling to get today's session together. And I'd like to turn it over to our 2 co-chairs of the networking group. We've got Valerie Liggins, the program officer for Cameron Foundation in Petersburg, and Denny Huff, who's the executive director of the Bedford Community Health Foundation in Bedford, Virginia, which is about halfway between Lynchburg and Roanoke, for those of you who don't know where Bedford is. And they are going to introduce our speakers and tee up today's topic. I will turn it over to you guys.
Thank you, Katie. Excuse me. Thank you. And thank you all for joining us today. This is really exciting for all of us, an opportunity for us to get together and talk about it through our networking groups here at Virginia Funders Network. And so just a little bit about the networking group. It's an opportunity for all of us to interact and connect with each other and other funders to look to improve the health outcomes in the Commonwealth. So we can learn and share our experiences, build community, create partnerships where we can, and advocate. That's a big part of who we are and what we should be doing. So the purpose of our group is to expand our understanding of the social, economic, and environmental factors that shape our health and well-being. Just a few of the goals of this network, of this group, is to build on the momentum and success of the Virginia Consortium of Health Philanthropy. Katie mentioned that previously, and that group did a lot of work. I was proud to be a member of that group, but this just takes it to the next level. So we're excited about this. We want to inform and educate our membership about what's going on in the state and the region and look for opportunities for actionable strategies and collaboration. We want to empower funders and communities with data and knowledge and tools so that Virginians can live a healthy life. We want to work towards educating members on the social determinants of health in terms of how they impact us all. And so a little bit about today's agenda. We're gonna have a wonderful presentation coming up shortly from Avenel Joseph. Then we'll get into a panel discussion, have some Q&A, and then we'll talk about what comes next for us. But before that, I think Valerie's going to talk to us a little bit about an article that was sent out regarding public-private partnerships. So Valerie, I'll turn it to you.
Hey, good afternoon, everyone. In the process of planning this session, Patty Koval shared a publication that really resonated with all of us on the planning committee. In the September 2021 Grantmakers in Health issue brief that was titled Public-Private Partnerships to Strengthen the Public Health Infrastructure, the importance of governmental public health agencies as the backbone of the nation's public health infrastructure was highlighted. This publication provides several key things for philanthropic organizations to consider when engaged and working with in partnership with our local health districts as we all seek to improve population health. This publication was sent to you in advance to those who registered, and you can also locate a link to this article in the chat. In the publication and within our discussion today, there are several key themes that are highlighted and will emerge. One is meeting local health departments where they are, asking the question, how can we help you? Two, being open to multiple types of collaborative relationships. Three, supporting data-driven partnerships. Four, encouraging multi-sector collaborations that will help us to identify and adopt innovative approaches. Five, engaging in policy analyses and advocacy to support our local health departments. And six, committing to long-term sustainable partnerships. You will hear the themes in much more detail from our panel of experts today. Denny, I will now turn it over to you to introduce our speakers for this afternoon.
Excellent. Thank you, Valerie. So we are excited about the expertise and knowledge that we have on this panel and in our audience as well. So we'll start. Dr. Oliver, M. Norman Oliver, he's our state health commissioner. Prior to this appointment, Dr. Oliver served as the Deputy Commissioner for Population Health for VDH. Before accepting the Deputy Commissioner position, Dr. Oliver was the Walter M. Seward Professor and Chair of the Department of Family Medicine at the University of Virginia School of Medicine. Dr. Oliver worked with others in the health department, other state agencies, and healthcare systems across the state to improve the health and well-being of all citizens of the Commonwealth. He is committed to a cross-agency and multi-sector approach to implementing population health initiatives. Next, we'll move on to Dr. Danny Avula. Danny is the director of the Richmond City and Henrico County Health Departments. He's a public health physician, board certified in pediatrics and preventative medicine, and he continues to practice clinically as a pediatric hospitalist. After graduation from the University of Virginia, attended VCU School of Medicine and completed residencies at VCU and Johns Hopkins University, where he also received a master's in public health. He is an affiliate faculty member at VCU, where he regularly serves as an advisor and preceptor to graduate and medical students. We also have with us Avenel Joseph, Vice President of Policy for Robert Wood Johnson Foundation. She joined in early 2020 as the Vice President for Policy. She brings a wealth of government, management, and political expertise to leading the Foundation's policy office and heading its Washington presence. Serves as a key member of the Foundation's senior leadership team and guides, motivates, inspires Robert Wood Johnson Foundation's commitment to its policy and government engagement work to help build a culture of health, one that enables everyone in America to live longer, healthier lives. We also have Dr. Cynthia Morrow, the Health District Director at Roanoke City, Alleghany Health Districts. Dr. Morrow grew up in Uganda, Ghana, Switzerland, and the United States, and that's fostered her passion for public health and social justice. She earned her MD and MPH degrees at Tufts University School of Medicine and completed her residency training in internal medical at the Medical University of South Carolina. Prior to moving to Roanoke, she had a long history of working in local public health in Guam and New York. Dr. Morrow was the Lerner Chair for Health Promotion at Syracuse University and Professor of Practice in the Department of Public Administration and International Affairs at the Maxwell School of Syracuse University. She served as Commissioner of Health for Onondaga County, New York from 2005 to 2014, during which time she earned numerous awards. She continues to serve as faculty at Virginia Tech Carilion School of Medicine. I think I'm missing someone here as well. No, I think that's everybody. Sorry about that. You may recognize certainly our health district directors. They've been on your TVs probably for the past 18 months. So they may not be strangers to you, but we're thankful we have everyone here and we appreciate it. So I will turn it now over. I believe Avenel has her presentation.
All right, thank you so much, Denny, and so happy to be here for this inaugural meeting. Let's get my PowerPoint up here. Has that worked? Can I get a nod? Okay, great, thank you. Wonderful, so great to be here. Good afternoon, thanks again for inviting me. For those who aren't super aware of Robert Wood Johnson Foundation, we're the largest foundation in the US dedicated solely to health and healthcare. We are committed to harnessing and leveraging our grant-making partnerships and voice to advance federal, state, and local policies that are evidence-based and equity promoting. As the Vice President of the Foundation's Policy Department, I help our organization make sense of our political environment and successfully navigate it. We are committed to promoting public policies that maximize access to quality, affordable healthcare and create communities that are healthier, more inclusive, and provide everyone in America the opportunity to thrive. So today I've been asked to give a brief flyover view of the federal landscape and what to expect over the next few months. I'm going to try to pack it all in as quickly as possible. There's a lot happening. I'll provide an overview of the Biden administration's COVID-19 progress, share some updates on the key fall legislative priorities, and offer a few other insights from the administration in states and in Virginia in particular before taking any questions. So it's impossible to overlook how the COVID-19 pandemic has continued to shift the political landscape in very drastic ways. The Biden administration came in hoping that the first 2 quarters of the year would focus on COVID-19 and vaccination rollout, and then the president would be able to quickly pivot to a more proactive governing agenda. As we are all aware, especially in the wake of the Delta surge, public health efforts and attention around COVID-19 are far from over. With FDA's recent approval of COVID vaccine boosters for adults and the pending approval for a COVID vaccine for children aged 5 to 11, new logistical, communication, and rollout challenges have continued to plague the administration. We are also expecting the finalization within the next few weeks of the federal mandate for large employers related to COVID vaccination. Throughout the entire pandemic, we continue to see the massive ways in which the economy has been impacted, including impacts on supply chains, restaurants, and tourism numbers, as well as inflation. The administration is keenly aware that the pandemic is its priority, and addressing it is also the most important way to rebuild our economy in the short term. While COVID-19 continues to dominate the administration's efforts, we've also opened this new chapter with several major legislative priorities pending within the halls of Congress and being carefully negotiated between Congress and the administration or the White House. These next few months are truly pivotal with the bipartisan infrastructure package, lovingly called BIF, the budget reconciliation package, which contains much of President Biden's Build Back Better plan, and the debt ceiling, which are all inextricably tied over the coming weeks. And of course, we also have to fund the government for fiscal year 22 by the December 3rd deadline. We'll dive a little deeper into reconciliation in a minute, but I do just want to take a moment to emphasize what a delicate situation this is. Even within the last few weeks, it has become increasingly clear that there will be no movement on the bipartisan infrastructure bill without an agreement on the reconciliation process. As a reminder, reconciliation is a process by which legislation can be passed with just a simple majority, meaning in this case that it requires the support of all 50 Democratic senators in order to pass. While the timeline is incredibly unclear and negotiations on reconciliation are ongoing daily, it's unlikely that either of these bills will pass before November. On the debt ceiling and debt limit, the president signed just last week a temporary increase that will keep the US solvent through December 3rd. Just a reminder, because I think these terms and processes can get really confusing, raising the debt limit is about paying for expenses that the country has already accrued. And since 2001, we've approached the debt limit 17 times, and each time Congress has voted in a bipartisan way to raise or suspend the debt ceiling. This is what happened just last week as well, when we had 11 Republicans join every single Democrat to pass a short-lived fix. What is a little bit unprecedented about the current debt ceiling debate and why it might feel like it's getting a lot more attention than normal is that Mitch McConnell, the leader of the Republican Party, has said he will not work on a longer-term solution on the debt ceiling with the Democrats. The Republican Party wants the Democratic Party to do this on their own, using the reconciliation process that is already under negotiation. The Democrats, on the other hand, argue that the Republican agenda and various Trump-signed measures are what have gotten us to this point with our debt and should be addressed with ownership by both parties. So as a result, we have a little bit of a political conundrum that has incredible implications on the government's credit rating, market volatility, and interest rates if they're not all sorted out well before the December 3rd deadline. And if that wasn't enough, Congress must also address the continuing resolution or government appropriations for fiscal year 2022. So unlike the debt ceiling, which is about paying for things that have happened in the past, appropriations is about how we are funding for the next fiscal year, which actually began on October 1st, in the beginning of this month. Congress still has 9 of the 12 remaining appropriations bills to pass that are needed to fund the government for fiscal year 2022. In the backdrop, the House and the Senate are working to pre-negotiate the details of these bills before the government is slated to shut down on December 3rd. I think the last thing any of us want is a government shutdown in the middle of an ongoing pandemic. So much is at stake in the reconciliation package. Many of RWJF's own grantees, I'm sure many of your grantees, are defending some of these key health, social, and economic provisions. As I said, our physical infrastructure bill can't pass without reconciliation, which has been known as our social infrastructure, our human infrastructure bill. And reconciliation requires all 50 Senate Democrat votes to pass. The House Reconciliation Bill, released about a month ago, revealed $3.5 trillion of investment in children, workers, and healthcare that will enable more people to reach their full potential and share in the nation's growth. The bill includes a range of policies, many more than I could fit on this one slide. It covers everything from climate change interventions to childcare that attempt to address some of the nation's long-standing disparities that have driven starkly unequal opportunities and outcomes, whether that's in education, employment, health, or housing. And some of the policies and structural systems that have fueled substantial racial income and wealth gaps. Many of the policies and programs included in this bill have a substantial track record, have a substantial track record or strong base of evidence that demonstrate the significant benefits that these investments would deliver. Nonetheless, as negotiations continue within the various poles of the Democratic Party, we now realize that this bill is going to be far less than the original proposed $3.5 trillion. While we don't know what the final top line number is yet, it's likely to be much closer to $2 trillion, which sets up this robust debate about what provisions will stay, which ones will go, and which ones will get truncated. And while it's still too early to say for sure, there's a lot of support within the Democratic Party to not completely eliminate any of the very important measures in this bill. But in any scenario with a lower dollar figure of investment, we're likely to see cuts in key healthcare related policies, either in structure or in duration. I wanted to spend just a little time on appropriations and funding for public health. As many of us know all too well, federal support for public health surges around public health emergencies. It's happened in H1N1, it happened for Zika, it happened for the Ebola virus outbreaks, and then that funding quickly wanes. The public health community is hoping for a different outcome post-COVID, where sustained higher investments in workforce, data modernization, and global health are made. We're starting to see signs of that in bills passed or proposed this year. For example, the American Rescue Plan passed earlier this year included $93 billion for public health, including $7.5 billion for COVID vaccine distribution and administration that supported state, local, tribal, and territorial public health departments. Under the original $3.5 trillion reconciliation bill, there was more than $50 billion dedicated to public health. This number is likely to, again, be decreased as negotiations on the bill unfold. And finally, most recently, we have the fiscal year 2022 health appropriations bills, which have passed the House and have been released in draft form in the Senate. And while the numbers in each of these bills are different, in either case, we're slated to see the largest increase for CDC in 20 years across a range of programs, including infrastructure, public health infrastructure, immunizations, and social determinants of health. Coming back to the administration, last week we heard that President Biden is likely to nominate former FDA, Food and Drug Administration Commissioner Robert Califf to the role. Califf previously served as the commissioner for the last year of the Obama's second administration. The White House has not finalized the decision, but he is the only candidate that's been floated in months. And the FDA has been without leadership since the start of this administration, with key issues like COVID vaccine approvals, drug approvals, tobacco control, all under this agency's purview. We have also continued to see the administration's efforts to roll back Medicaid work requirements that were approved under the Trump administration. So while this is mainly a DC update, I just wanted to spend a few moments on the state landscape. Their special sessions are starting up again around the issue of redistricting, including in West Virginia, Arkansas, Alabama, Delaware, and Iowa, with more expected by the end of November. 19 states enacted 33 voter suppression laws, including making mail voting and early voting more difficult, imposing harsher voter ID requirements, and making faulty voter purges more likely. Over 400 bills have been introduced in 2021 alone in 49 states to attempt to purge voting rolls as we head into the 2022 midterm election. ongoing efforts to make voting more restrictive are still very active in special sessions. Amidst these attacks on voting, states are still pushing through laws that expand voting access. And Virginia, in some really great news, is among the 25 states that have enacted laws this year that actually expand voting access. The American Rescue Plan implementation campaigns and strategy are ramping up in over 12 states and in some localities, working to build community resolutions and engagement strategies to influence spending and allocation of ARP funds. The work will likely have a large presence in the 2022 legislative and budget sessions. Virginia has significant unspent ARP funding, is about $700 billion. That's at the state level alone. And the upcoming legislative session in Virginia is quote unquote the long session. And the start of this will open up the 60-day window period to shape the narrative on how these funds are going to be spent. And of course, couldn't end without mentioning the high stakes for the upcoming gubernatorial election here in Virginia. It is a proving ground in many ways for strategies that would help determine control over Congress in the next year. And at the same time, all 100 seats in the state's House of Delegates are also up for grabs. We know that Virginia has proven to be a good barometer of midterm elections. Since 1978, the party that has won the state's governor race has gone on to gain seats in the House of Representatives the following year, 8 out of 11 of the times. So all eyes are on Virginia this coming November, and will have a large role in shaping what the electoral strategies and conventional thinking will be as the country heads into the national midterm elections. So these are just some of the highlights and the fast changing demographics. Tried to pack a lot of punch in there. Hope it was helpful. Happy to take any questions you may have.
And before we jump into the panel discussion, if you do have questions for Avenel or for our panelists as we get into that section, please do put them in the chat and we'll get to them as we're able. Avenel, I'd like to thank you. That was very helpful for me. I'm not a policy person, and I followed along with what you were saying and understood it. Thank you so much for really great information in a really accessible way.
No problem. Should we move on to the panel?
Yeah.
Let's do it.
All right, great. Well, we are have such a great panel here today, and I'm happy to have the esteemed opportunity to moderate. I think we'll start by asking a question of Dr. Norm Oliver. I wonder if you could help explain the funding model for health districts to those who are on the call today.
Thank you, and I just want to add my compliments to you for that very comprehensive summary of what's going on. It can be very confusing trying to follow it just day to day in the press. So yeah, you did a really wonderful job. Thank you. Also confusing is the funding of our local health districts. Those of you on the line know that this is a so-called centralized state health department. So we have 35 health districts, about 120 or so local health departments. Those 35 health districts are all part of the, well, that's not exactly true, 33 of those health districts, excuse me, are part of the state health department. And 2 of the health districts, Arlington and Fairfax, are locally administered health districts who have a MOA with the state health department. All 35 health districts have a cooperative agreement with local jurisdictions, and the local jurisdictions provide funding. A very complicated model has been set up for that. That model was put together about 40 years ago and has not changed. And as a result, there's all kinds of issues that come up that restrict the ability of some of our local health departments to really perform as well as they would like to. There's also just some inequities in that local jurisdictions are not all the same, and some jurisdictions have the capacity to provide far more support to the local health department than other local jurisdictions do. And that builds up some inequities where, for example, you can be doing the same job in one local health district and being paid significantly more than someone doing that very same job in another local health district. We have presented some legislation to the General Assembly to address the funding model. But I think one of the real opportunities we have here in talking to our colleagues in philanthropy is to look for ways to build partnerships that will help augment this funding at both the local and the state level. But my colleagues who are directors of local health departments on this panel can speak actually much more authoritatively on this issue.
Yeah, thank you for that. And I'd love to turn to Danny and Cynthia and get your perspective on what that might look like in terms of this impact of the funding model on your health districts and where that means that gaps show up that maybe funders can be helpful with.
Yeah, I'll start. I think we've heard over and over during this pandemic the refrain of the chronically underfunded public health system and how our ability to respond to COVID, I mean, sort of the comprehensive pandemic response has really shed a light on that. And when I look at our funding, there's so much that public health departments are asked to do. I mean, communicable disease is one element of what we do, but we're also, we have a team of restaurant inspectors that are going out and inspecting every restaurant, again, to prevent the spread of foodborne disease. We have educational programs in schools. We are providing some degree of clinical services. We do policy work. So I think part of what has led to underfunding has been, almost a lack of marketing on our parts, right? Like really explaining to our decision makers and legislators what the work of local public health is, and therefore why it needs to be supported and funded. So because of that limited understanding of some of our legislators, that results in a kind of myopic view of what gets funded, right? So like, I really understand restaurant inspections as a mandated service. We've got to fund that. I really understand direct clinical services like prenatal care or family planning services, and we'll fund that. Everything else feels kind of out there. And I think that's what we've been up against for decades and made some small incremental improvements in. But there's a lot of work that we've got to do, and COVID has certainly helped with that in helping decision makers understand what we do. And thankfully, philanthropy has been, at least in my experience in Richmond and Henrico over the last 12 years, extraordinarily helpful to us to be able to try new things, to grow new business lines in our organization that maybe our governmental funders don't always understand or aren't as intuitive, but philanthropy, because they've got flexibility, because they're thinking a little bit more broadly in some cases, are willing to fund. And so it's allowed for a lot more innovation to have really tight connections with our local funding community.
Thank you for that, Danny. Cynthia, anything else to add from your perspective?
Yeah, just piggybacking, I think that because of the way the funding is structured, we really are focused on those mandated services. And so frequently, if we look at burden of disease, what's killing us outside of obviously the COVID-19 pandemic, it's chronic diseases. And we really just don't have an opportunity at the local level to do meaningful work in chronic disease prevention based on the funding, which means that we really need to work with our partners to try to do what in some other states would be part of our bread and butter. And I think that for me, and we can talk about this a little bit later, it's really important that at the local level, we look at our community health assessments and we let, as you mentioned earlier, data drive our decisions and really move those partnerships. And at this point, we don't have a funding model that supports having our community health improvement plans married to our community health assessments in a way that allows us to do local actionable programming and services. Now, that being said, under Dr. Oliver's leadership, I think that this is a really exciting time for local public health in Virginia, because I think that the door is opening wide for us to have new opportunities to explore these collaborations and really create some amazing public health programming at the local level.
I wonder if we could just dig a little bit deeper on that, Cynthia, with maybe an example or two of how that relationship building around these funding streams happens with the local government agencies.
Well, so just, I can give you a really concrete example. Because of all of the COVID funding, our local jurisdictions, particularly if I look at Roanoke City, where we have huge disparities, of course. We just this year, we have sort of a landfall of, or a windfall, I say, of funding from the city of Roanoke. And it's going to allow us to look at hepatitis C prevention. It's going to allow us to look at some infant mortality disparity reduction, but that's unusual. And working with the city with that local funding, we're going to be able to do some short-term programming, but there's nothing in our state budget that's going to allow that to continue. And I'm really hopeful that we are going to be able to work with some of our community partners to build sustainable funding around some of their programs. And that's really what we'll be using this one-time windfall funding for, is to try to build those relationships and identify sustainable models with our community partners. But it's tough without funding of the local health department, and with really our funding being primarily either mandated or revenue generating, the clinical services. We just don't have a big window for that now. But again, I'm very optimistic with meetings like this, understanding that public health is a team sport, and with the leadership that we have in place right now.
Thanks for that. Dr. Oliver, I'd love to return to you again. One of the things that we've been paying really close attention to at RWJF, but also has been a real impediment from the national perspective, is around a better understanding and better collection of data that captures race and ethnicity. And I wonder if you can talk to some of the challenges that you see on the state level of data collection and capturing data by race and ethnicity, and maybe even other factors, especially in times of crises, and what we might need to be doing better now to better encourage data-driven partnerships in the future.
Thank you for that question. Yes, this is a huge issue for us as we entered the COVID-19 pandemic response. When we were getting information from healthcare providers, healthcare systems, and so on around vaccination, for example, it was not a requirement. We asked that they provide us with data on race and ethnicity, but it wasn't a requirement. And we found initially that we weren't getting all the data that we wanted or needed. So that became a question of getting out and really talking to them. Danny was, as our state vaccine coordinator, played a huge role in talking to leadership at healthcare systems to work on that. I think Virginia did well because of the fact that we had in place a chief data office and a chief data officer, Carlos Rivero, who played a very critical role in helping us figure out ways of enhancing our data and extracting data that we actually had on hand to augment what we were getting from the front lines. And if you look at the data that we have now around race and ethnicity, it's very high quality, and I think is an exemplar of what needs to be done around the country. That being said, really good data collection is a paramount need in public health. You mentioned in your presentation the issues of data modernization, and that's sort of foundational to that. And we need really good data collection. We need to make it electronic. We were getting lab reports on fax machines. You know, we had to hire a whole new staff just to do data entry from the paper records we were getting into our computers, our data systems. We've gone beyond that. Almost virtually all of our labs now are doing electronic lab reporting, but the case reporting, lab reporting, all those sort of data collection need to happen. We need to be getting the appropriate demographic information so we can, when we're looking at our work with that health equity lens on, we have the data there that to help drive the interventions that we need to do and to ensure that we're carrying out our work in an equitable fashion. But it's more than that. It's also building the data systems and the architecture to handle it. It's thinking through how to do the data analytics and the reporting so that the reporting becomes stuff that's really usable by our frontline public health workers, by other clinicians, by people in health philanthropy and others who are looking for the data to help drive their decisions as well. And it ties into the workforce issue because if we had all of that technology, we also need to have the people who know how to use it, right? And use it the most efficient way. And that's another huge challenge that we have. We have a very small number of people who are able to do that. Now, what we've been doing most recently with the ARPA funds and CDC grants and other things that have come down the line in the course of the pandemic is instead of just taking that money and plugging it into the usual spots, for short-term projects, we're trying to use them as a catalyst to build back public health in a way that really builds it back better, I guess is the way to look at it, right? So on this data question, for example, one of the things that we're doing is we're building up our capabilities by hiring people who can do the sorts of things that I was just talking about, building up those data systems, and working on that whole data modernization piece. But the idea here, and also very importantly, building enterprise sort of data architecture, and so that it becomes something that's a resource for the entire Commonwealth, as opposed to doing it here, there, across the Commonwealth. So those are things we're doing. We're trying to transform public health, and in doing so, I think that it's very clear to us that it can't be done with a very narrow view that this is something that's all about the Virginia Department of Health. To improve the health and well-being of the residents of the Commonwealth, it's going to require that whole public health ecosystem, which includes philanthropy, includes faith-based organizations, community-based organizations, local jurisdictions, all those folks who are working in that gap between where we are and where we want to be. We're all doing our thing trying to close that gap, right? But we need to figure out a way to work together where we're mutually beneficiary, right? We're helping each other close that gap, and we'll have a lot more impact. So we're working hard on building that kind of coalition, and coming up with a roadmap for how to transform public health in Virginia.
Yeah, would love to invite some ideas. Danny, Henny?
Yeah, thanks. Oh, good. I still have a landline, guys. So, as Norm was talking and Cynthia before him about the kind of assessment function that we play as public health, I mean, that really is one of the foundational roles of the health department, to collect data, to translate that data, to help communities understand what the health status of that community is. And it has deep ties to equity, because if we're doing our job to actually look and disaggregate that data by race or socioeconomic status or geography, we tell a much fuller and clearer picture to our decision makers and to our communities about what's going on. And I'll say that, we have not always had that expertise. And as you look around the state, different districts have that to varying levels, and the state is growing in their ability to do that as well. And so I see, and I think we've seen during COVID, that this area of how we collect, translate, like sort of build narratives through data is going to be crucially important for positioning public health priorities moving forward. And as I think about ways that foundations can support and connect with the work of health departments, foundations do much more than just give money. I think my friend Mark Constantine has taught me a lot about the different kinds of capital that foundations have, and reputational capital and convening capital. And one of the great initiatives in the Richmond region, the community foundation drove, was the Greater Richmond Regional Collaborative had really beautifully designed health, social, educational outcome priorities that were really simple and easy to understand and easy for the regional governments to galvanize around. And that was done through a thoughtful analysis of data, but then also the translational work of how do we market that basically to our communities. So I think there really are a lot of opportunities for foundations to lead the charge on how data is presented and digested by our communities.
Very helpful. Thank you, Danny. I think that's what many of us want to understand on the call, is where can funders play a role in this, particularly when it comes to data. It seems like, oh, this is a responsibility for the federal government and state and local governments to sort of figure it out. But I think there are lots of opportunities for funders to help push toward the goals that we want to see here, and all sorts of ideas of how to make that happen. So thank you for some of those tangible suggestions. I'd love to, I'll go to Cynthia and Danny and Norm. Any of you can speak to this. I wonder if we can talk a little bit about innovative strategies that are needed to create systemic change in communities. We talked a little bit about trying to promote racial and health equity and the need for data to help inform that. When we're trying to think of a Virginia that is more equitable in its health outcomes, what are some innovative strategies that might help there, and where can funders be helpful?
I think I know that from my point of view, one of the key things that needs to happen there is for a bi-directional kind of collaboration between the communities that we serve and our public health system. And I think having, and that happens on the front lines, that happens in the local health districts. I believe that their ability to partner with communities and that they're serving, Black and Brown communities, the rural communities, other really vulnerable communities, can be enhanced by things like having a very robust system of community health workers who are really embedded in those communities. I know that various philanthropies have helped us do that kind of work across the Commonwealth. So that would be one specific example. But Danny mentioned the convening capabilities of funders, and that is also very important, being able to bring together stakeholders from these communities who can work with local health departments in doing the community health assessments and figuring out what the actual health priorities are in a local community, and then developing the health improvement plans that can address those things. Those are a couple ideas that I have.
Danny,
Brett?
Cynthia, sorry, Norm, did you have something else?
No, I was going to say Danny or Cynthia could actually give more specific examples from their local areas.
You're taking over the moderator role. You got it.
Well, you know, I think from our perspective, and I want to be transparent, my experience in Virginia is pretty limited. I've just been here for a little bit less than a year. But one of the things that we're really trying to build in our community is, as Dr. Oliver talked about, with our COVID funding, we've really been able to build this amazing team of community health outreach workers to address COVID, to look at health equity, to really build the bridges that we need to build to be the effective chief health strategist in our communities. We're also, with our community partners, and this is where I think some funding could be really helpful, is we're also looking more at our peer support programs, particularly, you know, for us in Roanoke City, we're dealing with substance use disorder, hepatitis C, and I'm sure this is this is absolutely happening across the state, across the country. But in order for us to really, if we take hepatitis C, I know I mentioned that earlier, we know that some of the barriers that are individuals who are experiencing substance use disorder, who have hepatitis C, they have so many barriers, so many social and structural determinants of health that are impeding their ability to get the care that they need and deserve. And having peer support specialists who can build that trust, engage individuals, bring them into care, and help retain them in care helps at the community level, at the public health level, and at the healthcare delivery system level. And I think that for us, that's where we're putting some of our, if we think about innovative strategies, that might not be innovative in some parts of the country, but for us, particularly in Southwest Virginia, that is innovative. And I think it's really important to recognize we talk about inequity in so many ways, but the political differences in different regions in Virginia can create challenges from a public health perspective. And we may not have political buy-in for something that may be really important, and depoliticizing it by getting it outside of a local government can be really important. So I've sort of talked about two different things, but looking at meeting people where they are, using people to be trusted connectors, and making sure that we have flexible collaborative partnerships that can meet people where we as a local government may not be able to.
Couple of examples that come to mind for me, when we talk about foundations trying to impact system change in local communities, one is really around investment in leaders, and that's, you know, agency and you know, kind of organizational leaders, but it's also grass tops community leaders who really are closer to and representative of the voices of the neighbors that we're trying to serve. And I think, you know, Richmond Memorial Health Foundation, so I served as a trustee there for 8 years, and Mark, who really should be talking instead of me about this, has just been an incredible leader in so many regards. But one of the real efforts over the last few years of RMHF has been our Health Equity Fellowship. And so we have a cohort of leaders from the Richmond region that RMHF has kind of built a curriculum around, and really taking notes from RWJF, who has done this so well for so many years on a different scale. But I think the Health Equity Fellowship really took this cross section of institutional and grass tops leaders taught them about the principles of health equity, and created a community, a network for them to start thinking about, okay, how can our organizations work together, or how can our communities work together? And so that like starts to get at how some of the systems of power in our community get broken down through relationship, and the foundation is creating the platform or the medium for that kind of work to happen on. The other example I'll give is just about like the I guess the vehicles of care or connection that we've as the health department have been involved in. About 12 years ago, as we started mapping our data, saw that many of the public health outcomes we were concerned about were happening in public housing communities and other communities of concentrated poverty. And so that began through a lot of conversation and connection with residents. Began our work with a model called the resource centers, where we were given vacant apartment units or vacant buildings in these neighborhoods, and we're able to outfit those and provide some clinical services, some navigational services, and ultimately hire residents from those communities as community health workers. And while that was a data-driven approach, we saw a need, we partnered with the communities. None of that could have happened without foundations. I mean, throughout that whole decade-long evolution, we're now working on our 9th site in Richmond and Henrico. But over the last 10 years, it's been RMHF, the Virginia Healthcare Foundation, the Community Foundation, some of our health system partners that have made investments year in, year out to make that possible. And by giving us that, by allowing us funding to take these innovative steps, we were then able to show outcomes and really develop metrics that we could then take to our local governments and say, this is making a difference in our community, and we can't rely on philanthropic funding forever. And so that's resulted in the addition of line itemed dollars from the city of Richmond to be able to sustain these. So we now have about $250,000 coming every year to help sustain that infrastructure. But again, none of it would happen without the foundations in our community being willing to be the leaders and being willing to talk to each other and co-invest on some of these strategies.
Thank you so much for that, Danny. And it leads me to an audience question, but also just want to take a minute to say, if there's anybody here who has a question, you can pop it into the chat. You can go to the reactions part at the bottom of your screen and raise your hand, and that will pop you up if you want to ask your question live. But Robin put in the chat, and Danny, I think you sort of touched on this a little bit, but would love to hear from the others too, is what do you wish that funders would do more or less of? Danny, you gave some good examples of things that have worked really well in the past, and we can do some more of that. Are there things that we're not doing so great that we need to be thinking about differently? And maybe from the other perspective, I'm sure there are ideas from those who are on the phone of funders who wish that these health departments would be doing something different or more or less of something. And if you'd like to offer that, we'd love to hear it too.
So, I think this has been a pretty consistent area of learning for foundations, at least over the last 8 years or so that I've been really involved in them, which is then that more like a longer commitment, longer windows of funding. So we started out where we're basically getting funding every year or so, and then would have to show some outcome and re-up for that. I think foundations recognize the closer that they get to communities, the more they're working on some of this very challenging community-led work, that takes time. The relationship building, the identification of leaders, and just the rollout of some of this work takes time. And so to work really more on 3 to 5 or even longer year cycles of funding would be incredibly helpful. And I think kind of underlying that is the recognition that doing authentically community-led work is just a lot harder. And so some of the, I don't know, like operational or process-oriented outcomes that we're used to looking at to manage our progress in areas aren't always as relevant when we're really talking about doing the hard work of building leadership capacity in communities.
I think that one of the challenges is how different every local health district is in Virginia. So a lot of resources are understandably in Northern Virginia. And I think from my experience in Southwest Virginia, one of the great challenges is that we don't, it's completely understandable, but we just don't have as much access to organizations, to funders as there are in Northern Virginia. And I think that creates a different type of inequity, especially when our funding model is as was described earlier. And so, I think looking beyond borders and looking at where there are needs, which can be really challenging, I'm thinking about some of my colleagues and the lack of infrastructure at the local health department level. It's an iterative process. And I think that having that convening, that leadership that Danny was talking about could be really, really helpful. And looking at shared models in some regions, whereas, in Northern Virginia, it might be working with a health district, whereas in Southwest Virginia, it might be that we would need to have health districts come together, which is a challenge. But I think that a lot of us are up for that challenge because we are different. And I think that creates some, the inequity that I think we experience with respect to access to funding creates a whole nother cycle of challenges for us. But I think, one of the things that Danny mentioned, leadership, is something that is so important. Convening is so important, and it may be that the convening is more important in areas like Southwest Virginia, despite the challenges and the barriers of that.
Got one more for the do more of category. There was a pretty recent example in the midst of our COVID response where, well, maybe I'll tell the story and then sort of draw the take homes from it. Early on in the pandemic, Richmond really flagged nationally for the disproportionate impact of the disease on our Spanish-speaking community. So a lot of our Latino residents live in the south side of Richmond, overlapping Chesterfield, which is the big county to the south of Richmond. And just 44% of our cases through the month of April were in the Hispanic community. And despite having a 7% baseline Hispanic population in Richmond. So that raised a flag for the CDC. We engaged a conversation with the CDC. They started working with us on strategies to contain disease in non-English speaking communities. And that resulted in the CDC Foundation saying, hey, we'd like to make an investment in Richmond and Chesterfield. Knowing the constraints that we have on spending and moving money, there's just not a lot of agility in government. And so we brought the foundation community in, and I know there was a lot of work between Richmond Memorial Health Foundation and the Community Foundation to think about how do we leverage this huge investment by a national foundation. And Scott Blackwell and Mark just did great work in bringing the funders in our community, philanthropic, governmental, and some other outside foundations. And we leveraged that $500,000 into another $2.2 million to specifically meet the COVID-related containment and kind of practical support needs for our largely Spanish-speaking and undocumented communities in Richmond and Chesterfield. And there were a couple of key things in that. One was the willingness to come together with other funders and really think about how we're going to co-invest and leverage opportunities. Two was being willing to be the fiscal sponsor in this particular scenario, because we as the health department ended up not accepting the money and instead having that money go to a foundation where they could quickly get it to trusted partners on the ground, to nonprofits who could hire residents quickly in this rapid response scenario. And so that step of being willing to take on fiscal leadership and then really sort of be flexible with their program staff made a huge difference in our ability to garner more funding and get it to the places where it needed to go quickly.
I think it's really important to understand the impact of that in health outcomes, right? It had a huge impact in increasing our ability to reach that community, which means, I mean, if you look at our stats now, we started out with a vaccine rate ratio between the Latinx community and white community of about 0.3. We now have it totally flipped around with our vaccination rate in the Spanish-speaking community far higher than the exact vaccination rate in the white community. In a similar fashion, we've seen that happen in the African-American communities around the Commonwealth. But it's because of work like what Danny just described that we were able to do that. So it's really important in terms of health outcomes. It's important from the equity point of view. And these are all things that all of us share, right? These are goals, these are visions and outcomes that we're all seeking to achieve.
Thanks so much, Pat Matthews. You're not Patty Koval, but that's what your name says. Thank you for using the raise hand
Not quite
function.
sure how that happens, but no, that is. Thank you. Just want to push back a little bit on what Cynthia said. I run the Northern Virginia Health Foundation, and we are the only health foundation that funds all of Northern Virginia. And depending on what the market has done today, we've got less than $36 million in our portfolio. There is another health foundation that is larger than we, but they only fund a portion of Fairfax and a portion of Prince William County. So the notion that we are replete with health funders is part of the stereotype of Northern Virginia that people who don't live in Northern Virginia have. But I will say that one of the things that we've done that's been really helpful is to issue several reports about the inequities in Northern Virginia. We've got a 13-year life expectancy gap in Northern Virginia. And we got Steve Wolf and his center at VCU to do a lot of work for us on the census tract level. Because when you look at zip codes, as most of you know, it hides a lot of inequities. And so I would really hope that as we are moving to collecting more and accurate data, that we drill down a little bit more so that we can really get a clear picture of what's going on in all of our jurisdictions. And to Danny's point about having the foundation be the fiscal agent, I also want to say that many health departments are challenged by the purchasing and contracting responsibilities in the Commonwealth, and therefore find it challenging to accept money from foundations. And there's got to be a way to fix that. And Norm, you're just the guy to do it.
Yeah, thank you. Thank you for that. I think that I still need to learn the landscape. So I appreciate that correction. I think that one of the things that you mentioned that I was just about to raise my hand, what we hadn't really talked about that you just mentioned with VCU is I think that there is this extraordinary untapped potential. Again, looking at Southwest from my perspective, my limited perspective, having funders really help support the academic partnerships. So we're trying to become an academic health department here so I have a position with the School of Medicine, Virginia Tech Carilion School of Medicine. Virginia Tech also has a program in public health and really leveraging the support that is available there that can help us not only put some programming into place, but build some of the evidence that we need, start doing some ROI work that we really need to get sustainable funding in the future. I think that there's a lot more that can be developed there. And I'm really looking forward to doing that.
Thank you for that exchange. Deborah, I see your hand has also been risen, so please.
Yes, thank you. Thanks to all of our presenters for providing such good information and getting us started in this conversation. At the Healthcare Foundation, we've covered the state, so we really have had an opportunity to get a feel for the very great differences that exist in this state, education-wise, income-wise, you know, the local governments vary dramatically in the amount of resources available to them to put into and invest in any activity, including public health. And so, you know, there's such a stark difference. I guess what I want to do for you, Cynthia, is affirm your original comments. You are, I believe, observing correctly that there is more of a deficit in terms of available resources in your region and further southwest than there are in other wealthier parts of the state. And so we know that Fairfax County government just has a lot more money, for example, to put into everything practically than we will find in other parts of the state. But it's not, so there is that, but I think that, I don't think anything is so simple as looking at just one aspect of things, or, you know, like the resources of government or what foundations might be around to be helpful. I think that strategies and approaches are just having to be different depending on where you're located, because the cultures are different around the state. The people then correspondingly are different in terms of the way they look at things. When you look at the educational levels around the state by locality, you know, Southwest Virginia is just at the bottom. And that's reflected then in so many other things like health indicators and highest rates of chronic illnesses and highest rates of bad debt for healthcare and all kinds of negative things that flow from all of that. And so, you know, we can have all the great ideas in the world, but if the resources aren't there and the receptivity of the population isn't such that, you know, you can engage, then, you know, one particular type of initiative that works well in one locality may very well not work well in another. And I just think that it's important to keep all of that in mind. It's not to say that there aren't models that can be successful around the Commonwealth, but I just feel like sometimes we lose track of that it's a bigger picture than maybe what we've been talking about so far.
Thank you, Deborah. Jessica, it looks like your hand is up, but I'm not, is it? Not sure. Okay, there you go. Oh, so it was blending into your wall in the background, so I couldn't quite see it. All right, please ask your question.
But yeah. Thank you so much. So hi, everyone. It's been a pleasure to be on this call and to listen. I am Jessica Mullen. I am with the OBC Healthcare Foundation, but prior to coming to the OBC Healthcare Foundation, I worked for the Portsmouth Health Department for about 13 years in a variety of settings. And as someone that I think I have a unique opportunity to view what it's like to work for a local health department. And now as a funder, two things that really impact me here in Western Tidewater is what was brought up earlier is around procurement. As a public health employee, I will tell you it drove me insane and I wasted a lot of time working on procurement. But as a funder, I am happy that I have that experience because I feel like it's an opportunity that I can work with our local health department to overcome some of those barriers before we get too deep. So I find that to be wonderful, but I would be ashamed, would not be, one of the reasons I know this is I had a conversation with a funder one time as a health department who looked at me and said, we often don't fund health departments because you can't spend the money efficiently. And as someone who was dedicated to my community, that was heart-wrenching, but I understood it. So one of the things that I try to do here is to overcome some of those barriers before we get too deep. But it tends to continue to be a problem that I think will take a long time to fix, but it was the right forum to bring it up. Another issue that we have here in Western Tidewater is, and I know it's not a surprise, is the constant turnover of health directors, not only in Western Tidewater, but I would also say in Hampton Roads. I'm dedicated to public health. I am still a huge public health advocate. I learned so much under Dr. Lindsay and Dr. David Chang that really still impact me today in my job. But it's very hard to continue to build relationships with our local health department when there is a constant kind of shift and change. And I know with the job that I have now, I would love the opportunity to help assist, guide, offer any kind of support that we could in helping VDH or the Eastern District work through some of those things so that we can be a strong partner and supporter of our public health system as it starts to come out of the really strenuous last 18 months.
Thank you, Jessica. Norm, you want to reflect on that or something else to say?
Yeah, I wanted to reflect on that if I could. Thank you, Jessica, for those comments. It raises an idea in my mind. I've thought about it before, and we just, dealing with COVID, it hasn't been one of those things we've acted on yet. But I wonder if we shouldn't do the same sort of thing that the CDC has done, right? You set up a foundation outside that then has a little more flexibility for doing things and acting in more nimble and more efficient ways. The other alternative is to spend God knows how many years trying to change the procurement regulations. That could take us a lifetime. But so that's one idea. I'd love to hear if others had other ideas about things that we can do in that regard. And Jessica, we'll take you up on your offer to help us out in figuring out how to get more leadership in the local health districts. It's a huge problem. Public health has gotten a lot more attention, obviously, in the course of the pandemic, and it's been good in some ways. Obviously, we've gotten more funding than we've had in any of our memories, and even if it's time limited, and we're going to use that funding and that attention to try to garner the support we need for really transforming public health. But unfortunately, there's been a lot of negative things as well directed toward public health. People have been working 24/7 for, I don't know, about 640 days straight now. They're tired, they're worn out, and doing the best they can to protect the health of the residents of the Commonwealth, and then to be attacked and vilified, as many of them have been, has taken its toll. And we've lost several of our health directors. Nationally, about half of my colleagues who are state health officials have either been fired or resigned. So it's been tough, and we'll have to work together in rebuilding and strengthening the public health workforce and its leadership. The positive thing on that, though, however, is that I really think that we've seen the resilience of this workforce. It's taken a toll. We've lost some of our troops, but in the main, I think we've proved a very resilient workforce, and I think it really speaks to the passion of the people who are working in public health, and to the support that we've gotten from those on this call and elsewhere.
Danny, I see your hands up. I also have a question in the chat, but go ahead. I'll turn to you first, Danny.
Yeah, so I think in hearing Norm's reflections on that, there's a really practical way that foundations can think about supporting health departments right now as we come out of COVID. Certainly the affirmation and encouragement, but also the investment in the frontline public health workforce. Are there opportunities to do smaller leadership cohorts, or something that feels restorative to those of us who have been in this work? Just an idea to throw out there. But one other thing, as we think about sort of the whole topic of this conversation, which is how do you build that bridge between the health department and philanthropy? I think like Jessica Mullen is an embodiment of that, right? The fact that she knows governmental public health so well and is now able to leverage that from a foundation, that is paying huge dividends for the health in that community. And so finding either, sort of shared staff models or board membership of current or retired public health officials, but the more that you can kind of build that connection through actual people who know both sides, it's been a game changer for us in the Richmond area.
Thank you. And so a question that came in through the chat is, how can funders be a resource for health departments to bridge relationships with both grass tops and grassroots leaders to support with community engagement and reach broader constituencies? I'll send that to Danny.
It comes back to the convening power, right? I mean, foundations, particularly health funders that have been doing, but really, no, I mean, all funders know the nonprofit landscape. Increasingly, they're knowing the less institutional landscape in communities, right? They're engaging these grass tops leaders, the civic and tenant association leaders. And so I think foundations have the ability to host a meeting, break bread together, bring people into a room and facilitate conversation, or offer shared learning together. And I think there's so many examples of where foundations have funded that kind of longitudinal learning cohort that then builds the connections and relationships that then can get unleashed on communities.
And I just want to jump in as well, as time is getting close. I think that for me, having funders at the table when we do our CHA process is really important. I'm sure my colleagues feel the same way. It doesn't really matter who gets the credit, who does the work, as long as the work gets done. So if we have a community health assessment process that truly reflects all of our collective needs, but most importantly, a CHIP process, a community health improvement process that isn't about what the local health district is doing, isn't about what the healthcare delivery system is doing, but is really about, and we did this in Onondaga County, where our CHIP had improve access to cancer treatment. And then under that, it listed what each organization's commitment to that that key indicator was, and having we would convene large groups, we meaning that the collective would convene groups around the community health assessment and say, okay, what are you willing to commit? What are you willing to commit? Put that in our CHIP. And that was really motivating, because then they had to report on it, and it wasn't about that the local health district had to do all the work. It was, how are we collectively getting the job done?
Thank you for that, Cynthia. I know we're getting short on time, and I really do hate to cut this great conversation short. You know, I think what I've taken from this is that there's a tremendous opportunity in the wake of COVID to really think creatively with the funder community about utilizing our toolbox to help in both short-term ways, but also setting the path for longer term structural equitable changes that can last for a really long time. So I hope that there's been some ideas that others have generated as a part of this conversation, and really appreciate being a part of it. And I'm going to kick it over to Katie, who has a few closing remarks.
Thank you, Avenel, and thanks so much to all of our panelists today. Really appreciate all that you guys have shared with us. It was really helpful for me, and I know it was with just the conversation alone, you can tell that it was helpful for other folks as well. This is the first of many for our Health Funders Networking Group. And our next session is going to be in January. That session will focus on behavioral health. And so we'll hope you join us. We're going to be announcing a date for that in just the next couple of weeks. So stay tuned, be watching the newsletter. A couple of other events that I want to bring your attention to. Next Tuesday, we're having a panel and publication briefing. Robin Mockenhaupt, our Director of Policy and Advocacy, is going to talk a little bit about our newest publication, The Power of Policy and Advocacy for Virginia Funders. We've got a great panel of funders who are already using policy and advocacy in their work, who are going to share a little bit about how they went about that. So I hope you'll be able to join us on Tuesday. For those of you who are interested in broadband, we are hosting our second session in our broadband learning series on November 4th, and that'll be all about philanthropy's role in really leveraging this $1 billion state investment in expanding broadband access. We've got a great panel of funders lined up who are working in this space. And then on November 17th, we're hosting our very first business meeting and anniversary celebration. We hope you'll join us. We're going to hear from some of our founders on why this organization came to be, all that we've accomplished together in our first year, and what we can look forward to in 2022 and beyond. Thank you, everyone, for joining us. Big thanks to our co-chairs and planning group for this session, and big thanks to my staff for doing such incredible work behind the scenes. We really appreciate it, and we look forward to seeing you guys all real soon. Bye, everyone.